Can you hear me, Dr. Young?
Oh yeah, I got
Okay.
you.
Well, thanks everybody for coming. We really enjoyed the turnout for last time and wanted to just keep it going and seeing what would be something relevant and something that would be interesting to everyone. And one thing that I first realized when just looking up different topics and things that came up, I just happened to look up Henrietta Lacks and I thought about her birthday, and it turned out that her 100th birthday was coming up. So we did something for that, as well as a story that came out of England about a month ago, where a young man, a 20-year-old Black British medical student, saw that on his clinical rotations, he had learned a lot about different diseases, but didn't really see the clinical teachings represented in colored skin. So he wrote a book called Mind the Gap. And with that, I reached out to him and we spoke for a little bit about just his experience and what led him to write the book. And coming up later in August, on August 14th, he's gonna come on and speak with everyone about that. And today, we're gonna just go over this idea of views from the ivory tower. And that's kind of a theme we're gonna stick to with the ivory tower of medicine. Thinking about the white coat effect, thinking about the authority and that whole dynamic and how that influences relationships between providers and patient populations, especially when the patient populations are oppressed or in a certain high-risk group. So these are two papers that I referenced a good bit. And in this paper specifically inspired the title of the Ivory Tower. And starting off with this quote, "From the American health system's very beginnings, race has been and remains a pervasive yet enigmatic issue, where institutional racism and all these points are detailed as different ways that race influences healthcare. And looking through them, you see institutional racism affecting clinical outcomes, indifference towards Black American health crises, unfair biased treatment, barriers to even enter the field, which is something that in the grand scheme of African Americans in America is relatively recent. Mainstream acceptance being an issue, acceptance of disparities. Repeated refusal of of discriminatory results, and irrational resistance to the creation of a united healthcare system that would very much aid certain oppressed groups and marginalized groups. And to begin looking back at some of the foundations of the institution of medicine and how some of the biases and prejudices date back before medicine was fully established as a field, and looking at Greek forefathers, Plato and Aristotle, who in their teachings assigned slaves as a lesser status and lesser intelligence. And looking at Aristotle, who within those slaves was particularly prejudiced towards African and Asian slaves. And one of the first times you see a specific prejudice against non-white individuals and perpetuating the idea that has grown to be white supremacy. And you see these ideas transfer with every major society that comes into prominence. So following Greek with the Romans, on to the Islamic empires, the caliphates, throughout the Renaissance, the Age of Discovery, the Enlightenment within Europe, and then coming to America. And on the right side, I can make this a little bigger for everyone to see. These are some certain things in America in the late 20th century that were attributed to Black people. And you can look through these and you see certain pathologies were just accepted as normal. among African Americans. And then getting to one of the first major incidences of healthcare and treatment specifically affected by the race of the patient population is J. Marion Sims in America. And he was a gynecologist who did experimental procedures to correct fistulas, where basically if a woman has a child or any type of damage to that area between the bladder and the vaginal wall, where later, afterwards, urine could constantly leak out and the smell could be horrible. And as far as lifestyle, make it very difficult for a woman. And being able to repair that meant completely changing someone's lifestyle and quality of life. But even with such a great advancement, a lot of these procedures and a lot of these experimental tests were done on slaves without any anesthetics, without any sort of pain relief. And it was a quote in his autobiography where he said that his procedures were so painful that none but a woman could have borne them. And it was specifically referring to a Black woman. And there's an NPR article I can put in the chat that goes into further detail on this. And it has only been recently where you see his legacy come into question. Because for a long time, he was accepted as the father of modern gynecology and obstetrics and gynecology. He had a statue in Central Park that was recently taken down, and in Alabama is becoming more and more controversial. And especially with him doing these experiments on slaves, then once he had perfected his craft, traveling to Europe and performing the full fistula repair on wealthier people using anesthetics and more ethical treatment. On the left, you see his statue in New York being taken down. And on the right, this is his statue in the capital of Alabama, Montgomery. And this link, I'm going to put it in the chat, and I also might pull up, is from yesterday, where the Montgomery Advisor, or one of the Montgomery news outlets recently did a story on him, speaking on how, let me pull up the headline. So everyone can see it. How he experiments on slaves and experiments on women that cannot consent. And in this new era and a lot of these new conversations, looking at the additional layers of how unethical his work was. And this is with the Montgomery Advisor. And this leads to the bigger question of how is medical education over time involved in this? And that is a bigger question that's really going to be explored more on August 14th. Just wanted to bring that up and think about that, where you see throughout history and even recently specific things being taught about certain races in regards to healthcare outcomes, lifestyle habits, pain, accommodations, the ability to tolerate pain. And that's something that's just continuing to be perpetuated. And the shift to kind of correct that. And if we could take a moment, Dr. Peterson or Dr. Van Wagner or Dr. Young, y'all can comment on your experiences with it.
Well, I think you've summarized everything extremely well to frame everything. And a lot of what we're seeing you discussed about has been historic, but it bleeds over in today, unfortunately, of one group of people denigrating another group of persons because of power. Ultimately, it's all about that, who controls or has power over somebody else.
Mm-hmm.
One of the things you just mentioned is extremely important, in that as time goes by, even though it can sometimes be arduously slow, that the next generations that do arise do have a responsibility to go back and look and try to identify what those injustices were in the past, correct them, and then to move forward to make the world better. And bringing to light what Dr. Sims did, if you want to call him a doctor, I guess so. But also the things that happened with the Tuskegee experiments,
Mm-hmm.
and more recently with this topic with Henrietta Lacks.
Right.
That historically there have been issues with experimenting on populations that don't have a role. Nazi Germany is another one. Joseph Mengele did horrible things to the Jews during that time.
Mm-hmm.
So it isn't, even though I think African Americans disproportionately have been affected. Why? Because Africa has been exploited for hundreds of years. Why? Because going to history, because the Europeans lived in a temperate climate and they had trees and they could build ships. And that's one reason that they were able to dominate the world, because they were able to build the ships, and therefore the African nations didn't have that same type of environment to do that. But that's getting off point. But it's about one group dominating another group and not taking into consideration issues that are important to them and vilifying them. We
Right.
still do it now. You go to war with somebody, you vilify your enemy to make them less human, to make it more justifiable to go and destroy them. But we have the same mentality a lot of places, that we denigrate groups of people to somehow make them less than us. But education, and I'll stop, but education is important. Civil discourse, bringing these topics to the fore, is how we expose this stuff. So as the old adage goes, that we are not condemned to repeat what has happened in the past, and also to correct those injustices.
And that's why we're here today. And moving on from that, and but keeping that in mind, we have the story of Henrietta Lacks, and Allison's going to take it from here.
Sorry, I didn't know if you noticed Allie had her hand raised. Did you want to say something?
Oh, my bad. I
Allie?
didn't. Oh, yeah, you can speak out. My bad. I didn't see that.
Hey, my name is Allie Hing. I'm an MS3 for those who don't know me. And I just wanted to talk about some lasting effects that I've seen about this on my clinical rotation. I'm on the OBGYN clerkship right now. And if a patient has Medicaid, the policy for female sterilization is they have to wait 30 days after their delivery to have this procedure done. And this is something that I've learned from one of our attendings, that this was put in place because of the history that's happened and the sterilizations that have happened to lower income women and women from minority, racial, and ethnic groups. And it was done in place to protect them, so that way they wouldn't get sterilized or have their bilateral tubal ligation without their consent. But what we're seeing is that a lot of people always complain about, why do I have to wait 30 days? Or even like attendings or residents talk about that. But the reality is that it's put in place to protect people. But by doing it later on, you're increasing their risk for it. By preventing women from obtaining their desired sterilization, it puts them at higher risk for unintended pregnancies. And there's a lot of harmful consequences that come about that. But I thought that was very interesting. And that was the first time I've seen something like that play out very prominently, but also something that we deal with every single day in the hospital.
That's good. And hopefully, for all the preclinical students, learning about this can help you navigate those situations when you see them come up, and learning about it in situations like this, then getting into the clinic and seeing it, that added dimension to it. So we have the story of Henrietta Lacks, and Allison's going to cover this.
Yeah, so once again, we thought that this discussion not only ties well into the discussion about medical racism and injustice that we view in the medical field, but once again, her 100th birthday would have been tomorrow, August 1st. And so we did that to celebrate her. So Henrietta Lack, she was actually born Loretta Pleasant on August 1st, 1920 in Roanoke, Virginia. And what I found interesting is that she grew up on former slave quarters that was owned by her family slave owners. So I think that just ties into more of the context of how this is not far removed from slavery at all. And so then she and her husband David moved to Maryland after the birth of their second child.
Okay.
That gets into how she showed up at Hopkins in the first place. So she was only 29 and she began to have abdominal pain and vaginal bleeding. And so Dr. Howard Jones, a Hopkins gynecologist, discovered a large malignant tumor on her cervix. And at the time, the treatment at the time was do radium treatments. And so when they did that, they also biopsied her tumor, and then a tissue sample was sent to Dr. George Gay's lab, and experiments were done there. But the important thing is that these tissue samples were taken without her knowledge. So then from then on, the researchers discovered that unlike other cells that they have acquired from different patients, Henrietta Lack's cells continue to populate. And so he dubbed the cell line, he created HeLa cells, which was taken from her name. And then this cell line went on to make very many advancements in the medical field, including the development of the polio vaccine by Jonas Salk. But unfortunately, Henrietta succumbed to her illness on October 4th, 1951, at the age of 31.
Okay, so we're about to bring in Dr. Young. And before we get Dr. Young in, just generally, if you were someone who hadn't heard of this story before the discussion was announced, or you're someone who recently read the book or recently read the movie, anyone can speak up and give your reaction to when you found out about it. You can raise your hand or unmute yourself. We can go to
So this is Nick Van Wagner, just real quick. So when I did my, when I was in getting my PhD in cell biology, HeLa cells were used frequently. And to my sadness, I didn't know where they had come from. And I don't know if anybody that I was working with knew where they had come from and how it had come to be that we used these cells. And it wasn't actually until the book came out that I learned this several years after. And it certainly is incredibly troubling to realize that there was no consent, there was no permission, there was no knowledge in the fact that we were using these cells. And in fact, I was using these cells. And so I really appreciate what you're doing in educating all of us and helping us understand more about this important individual. So thank you for that.
Yes, sir. Yes, sir. And do you think most people in your lab, when you were doing research, do you think many of them were aware before the book came out in 2010? Or
Yeah, Michael, that's a great question. I actually don't think anyone was aware. Well, let me say it this way. That's not a fair statement. It wasn't discussed. And I wasn't aware. And so I suspect that many of the graduate students were not aware either. In fact, I took a course in ethics in research. And again, this is a while back, but this was not a topic that was covered during that either. So again, I just don't think many people knew. Anyway, it looks like Allison has her hand raised again as well.
I think it's Nada.
Oh, Nada, sorry.
Yeah.
So I just wanted to comment on the fact that it was not really well known. Like, I hadn't really gotten into using cells until, you know, probably 2014, 2015. And at that point, it was kind of already well known or established. But it is something that's still pervasive in research that, unfortunately, African American patients, it is very difficult to recruit and or also consent subjects, just because of different barriers that are existent within their community to actually recruit them and to participate in clinical research as well. So unfortunately, it is one of the saddest things, because institutional review boards weren't really prominent at that time, which is a big, big thing. But once, you know, these things became prominent, it was really important to make sure that we are including people. Now, the problem as the IRBs developed initially was that the language may have been too complex for patients to understand, which did not account for a lot of the populace that was undereducated, especially in low SES communities. So now the language that we're always required to use for consent forms is on 7th or 8th grade equivalents, in order to make sure that everyone understands it. The consent processes are far more in depth and in detail because of situations like this. And honestly, even though there's still probably abuses that continue to happen, obviously there's still a lot that gets reported every single day. And obviously the vaccine trials abroad were a big issue. And I've discussed that in one of the Late Black podcasts, because we did mention that because malaria and HIV/AIDS vaccines were actually used abroad in Africa, and that was a complete abomination of a research study. So in all, like, it's still something that we're fighting to this day to make sure that we protect our patients. And even I can tell you, as far as ALS, because my last clinical research experience was in ALS, that was one of the things that we saw, was that all of the studies that had been done in terms of genetic testing were always in Caucasian patients. So the 9 or 13% of non-Caucasian patients that we had, especially African-American patients that we had, basically we couldn't tell them anything. So it felt really horrifying for me to be able to say, hey, we want your DNA, but realistically, we have no idea what this means for you as far as your risk of passing this on to your family. Right. So it was extremely horrifying for me to go through that. And I can tell you that it is something that I'm passionate about fighting for in the future, because it is important that we address this whole disparity in research for patients in the African American and even African communities.
Right. And getting to that and diving deeper into this topic, we have Dr. Carlton Young, the Assistant Dean for Medical Student Diversity and Inclusion and Director of 2 transplant programs, and really relating to this case, a graduate of Johns Hopkins Medical School. And from the picture to the glowing face in the Zoom box, the black really didn't crack, the same smile.
I'm old now.
All these years later.
I don't know where you dug that picture up, man. I'm old.
How you feeling, Dr. Young?
Well, again, thanks, Michael, for everything, and Allison for bringing this up. Well, a couple things, and I know you're going to talk about IRB consent later. I really don't know, and I doubt that they had permission way back when all this occurred. But even with that, during the time, by the 80s, there were IRBs, and that oversight was not correct. Okay, even if they didn't have it back then, her cells had become world renowned and used, yet no one ever went back to the family to let them know what had happened. And so that's egregious in and of itself. Well, I was there, and I was fortunate to be there primarily because of the efforts of Dr. Levi Watkins. He was a cardiothoracic surgeon. He was the first one to graduate from Vanderbilt's medical school. And then he was the first African-American to finish Hopkins as a cardiothoracic surgeon. Mm-hmm. A couple of classes ahead of me, Dr. Vickers was one class ahead of me, then there was another class. Prior to that, they would only accept 1 or 2 African-Americans a year. And so he got on the admissions committee and worked assiduously to try to increase the numbers, because he basically said, you're going to tell me that in this entire country, you can't find enough qualified African-American students to come to Hopkins. Well, we obviously proved that the people who were there were wrong. But even in that was the 90s and in the 80s, they still had that attitude against minorities. And Harvard, to their credit, has done a much better job of getting African Americans in their medical school than Hopkins did. But even while I was there, people mentioned HeLa cells, but they didn't mention Henrietta Lacks. It was only during that time that they even started to talk about Vivian Thomas, who basically taught Alfred Blaylock how to do the blue baby operation. And and while they were doing the first one with Tuskegee, Blaylock asked Vivian Thomas to come in the OR to help him, and everybody was flabbergasted. But Vivian Thomas had done hundreds of them, and he helped Blaylock do it. But it took, 30, 40 years before Vivian Thomas, who was African American, and there's a movie out on him and books about him, was being recognized. So it doesn't really surprise me that the story of Henrietta Lacks took so long. But you got to remember where Hopkins is. Hopkins is in East Baltimore. And East Baltimore is a very difficult area. If people are from Philly, it's like North Philadelphia, it's like Watts, it's like Compton. So the patients were indigent.
Right.
And so they didn't have insurance. So a lot of the times, a lot of the people who came there had significantly advanced disease because they didn't have care. And really, Hopkins had all this clinical material, I hate to say it like that, in which to experiment and grow on because of the population that they had. But that, I even remember, if you guys saw the movie with Victor McCusick, he was the big geneticist. He would walk around like God. I think he may have said hello or something, but it was that type of atmosphere. And Hopkins is very much a place of getting ahead and being world renowned. And so,
did it feel tense for you?
Tense? No, I was extremely fortunate. I did research as a student with a pediatric surgeon, Dr. Haller, who was wonderful. The folks reached out to me. So the docs that I worked with were fine. I think it was the people above them, the administration, those old folks who were just in there for so long, who had that attitude. Now things have changed. Right now, the head of surgery is an African-American cardiothoracic surgeon. He's the head of their department of surgery now. And prior to him, they had a female who was the head of surgery. But to get her there, it was horrible. They had surgeons leaving because how dare you bring in a woman to be the head of Johns Hopkins surgery? People actually left because they brought a woman in. But so it's that mentality, that
right.
true institutionalized idea. But overall, I did not have anything overt. They were like, they beat on everybody. They were hard on everybody. If you didn't do well, they just beat you up. But they beat each other up. But we did not discuss Henrietta Lacks, and it's egregious that it took this long for them to even acknowledge what she contributed. But it doesn't surprise me, which is the sad part. And someone and I forget who mentioned it. And even today, they continue to they continue to experiment with vaccines in third world countries. A person I listened to on the internet said he lives in Costa Rica, and he was riding his bike, and they went and he saw people lined up. He said, "What are you doing?" "Well, we're giving out a vaccine for COVID." This was 2-3 months ago, and it was and the lady gave him a brochure from GlaxoSmithKline. There is no vaccine now, but it was Costa Rica.
Right.
And so they were experimenting, who knows, on these third world folks. So this same thing has not changed in all these years, but by bringing these topics up and discussing them is extremely important to try to correct these things.
Yes, sir. Yes, sir. And I think Allison
I'm sorry.
is handling questions.
Yeah, so just tying into what you said, how, following with the questions on the screen, so how do you feel as a Black physician now compared to when you were actually a student at Hopkins about how the physicians there at the time capitalized on the Lax families' lack of education and understanding about the situation?
Well, it's egregious. And I think in some ways it probably still occurs now. You know, even though we have the IRB and try to, I think it's a lot less prevalent. And the difficulty with getting African Americans to sign up for studies goes deep, especially here in Alabama because of Tuskegee. And you even had that from the talk about the folks around Hopkins, they'd go there, but they were worried about going there. And we still have that issue with organ donation. We have a lot of, we are still trying to educate the minority community that that if you sign up for an organ donor, that doesn't mean you're not going to get cared for. Some folks still believe that if you sign your organ donor card, they're just going to let you die and take your organ.
That's very real. I remember when I first turned 16, my grandmother, she's about to be 80 in a little bit. And she asked me if I signed up to be an organ donor. And I was like, yes. I didn't really think twice about it.
Right.
And she was like, you might want to think about taking that off. And I saw that then how people in her generation, that is very much an accepted thing, where if you are a Black person going to the ER and an organ donor, that the perception is the physicians will let you die. Yeah. And Dr. Peterson, have you run into anything like that or seen that where people are afraid when it comes to the ER about that?
Oh yes, for good reason, but it's very clear there's a lack of trust with the medical community. So we have protocols in place where the person rendering care is not the person who approaches to ask about, would you like to be an organ donor? And I think that helps marginally, but still, if I or one of my colleagues walked in like, look, it doesn't look good, we're not sure this is going to be a survivable accident. And then 15 minutes later, someone comes in and says, hey, would you consider possibly donating organs? In some people's minds, those things are linked. And there's always that seed of doubt. Man, did that doctor maybe not do as much as he said he did because they just want to harvest organs? And I understand with all the injustice that's been around for so long. But it is tragic because it does make, organ donation and a lot of other really important pieces of care harder to render. So I think you have to be aware of it and be very sensitive to it. And I've seen colleagues get very frustrated with it, but until you walk a mile in their shoes, I don't think we really have the right to be that upset about it, frankly.
You handle it, Dr. Young.
Oh no,
were you saying something, Dr. Van Wagner? I didn't mean that.
Oh, I was just going to transition to the next question since Dr. Peterson alluded to it. So I guess between, Dr. Peterson, Dr. Young, and Dr. Van Wagner, if you guys have comments you want to add, how do you encourage this relationship today with encouraging trust between yourself and minority patients?
Well, I'll start off. I'll just let the guys take them off. I think, to be honest with you, it's harder for majority physicians to connect. It's not impossible. It's just harder. In our transplant clinic, it would not be uncommon to have one of my older nephrologists, extremely capable, ask me to go talk to a minority patient to try to help them even though he sat there, took his time. I said, fine, no problem. Let me go and talk to him. Because as you've already mentioned this, and what we're trying to do at our institution by increasing our numbers of underrepresented minorities in medicine is that oftentimes the minority population will connect and open up more to a minority physician. But that doesn't mean that white folks can't do it too. I've seen a lot of great physicians from all backgrounds. Sometimes it's just harder. But what do? I just try to be a person. You know, one of the things I'll go in and joke with the patient. I'll go in and get on their level. Hey, what you doing? How's it going? How's the family? Just speak to them like everyday folks, and then find out what's going on with them and listen to them. Find out what if I can't get through. So what's wrong? What's going on? And just take my time to see really what's concerning them. I get through the majority, but there's some folks I can't get through, and that's okay. And if they want to see somebody else, that's okay. And I think sometimes physicians just have to say, well, maybe I can't get through to this person, and maybe somebody else can.
Mm-hmm. Do you see it, or any between Dr. Peterson, Dr. Young, Dr. Van Wagner, do y'all see that with interacting with residents from medical schools that were in a very different city with a very different demographic makeup than Birmingham, and someone coming from maybe Minnesota or Idaho, and then coming into the heart of the Southeast with the predominantly Black patient population? Do you see difficulties adjusting to that in interactions?
Yeah, so I would answer that yes. That I think that there are challenges certainly for people who are coming into a new culture and into a new area who may not understand, or don't understand necessarily the history, and understand the perspectives and the experiences that people are bringing to that interaction. You know, I would add to what Dr. Carlton said, and I'm going back a little bit to the last question. But one of the things that I think is critical for me to do as I'm interacting with a patient, caring for a patient, is recognizing just kind of what I said, that we're face to face and seeing each other for a moment in time, but the experience, what we are each bringing to that situation is very, very different and complex. And so building trust, I think you got to earn it. And that doesn't happen in a 5-minute conversation. That doesn't happen, you know, in one visit. These are experiences that we haven't earned it, and we need to earn it. And when I say that, I may only have one experience with that patient, but I'm talking about physicians as a whole. If one physician treats a patient poorly, we've all treated that patient poorly, and that patient brings that to the next physician. So I guess what I'm saying is that it's a whole community effort to make it work, in my opinion.
I concur 100%. You're absolutely right. And that's why in the old days, they used to say becoming a physician was a high calling. That's old-fashioned term. And not everybody can do what we have signed on to do. It's hard. It takes time. It takes a heck of a lot of compassion and empathy. And it just takes time and to cultivate your ability to do that. And, you know, there's just no way around it. And Nick just summarized it. Each of us brings our own biases, our own backgrounds. And you walk through the door, you say, hello, I'm Dr. Such and such, you know, and all those things converge. And we have to be able to try to figure all that out in a short period of time, see where folks are coming from in order to try to take care of them. And it can be hard. Todd does it all. Dr. Peterson does it all the time. Emergency room, that's probably the most difficult place to do it, because folks are coming in, they're hurt, they're acute. They're not going to really want to sit down and have a long conversation about what's going on. It's all these different dynamics. And that's why medical education is so complex. You know, we're not only trying to stuff a boatload of information in your head, we're trying to build you up emotionally to deal with all of it, to be a psychologist, psychiatrist, as well as a physician. You know, just think of the gravity of what we're trying to teach you guys. It's a lot, and it's a lifetime learning process. It just doesn't end at the end of the 4 years after. I'm still learning now.
Absolutely. Yeah, and like Dr. Young was saying, that, you know, where I work clinically, it's an emotionally charged encounter with the majority of people I see, because, you know, they're in physical discomfort. You know, they've oftentimes had to wait several hours before they get to see me or one of my colleagues. And oftentimes, you know, by the virtue of our health system and our society, they very much feel disrespected. And one thing that I think is universal amongst all backgrounds is people want to feel respected and heard. And it's very important to try to develop some kind of connection with them. So Dr. Young was saying sometimes we'll joke around. I think it's also one of the first ways I start many of my encounters is, hey, it's so nice to meet you. I'm the supervising doctor. I want to apologize for how long you've had to wait. That's not right. But I'm glad you're back here now. You know, I want to do everything we can to make sure you get the care you need. And it kind of diffuses some of that anger when it's at least acknowledged by someone, you know, that happened.
Well, I think you touched on something, respect. See, the African-American community has been disrespected for centuries. And especially for an African-American male, the worst thing you can do is disrespect that person. Because you're disrespecting his culture, but more importantly, disrespecting his manhood. And so having the ability to go in and seeing all patients in a respectful and dignified manner is what has not happened after all these decades. But it is extremely important to do that because that's how you gain trust. Like I see the veterans now, I say thank you for your service, or regardless of what they do. Well, what'd you do when you were growing up? What was your job? And say that's great. You know, she was have people that were seamstresses. That's great. I wish I could sew. Or they were ironing because they seen some of these little old ladies with big old vessels. Because I do vascular. I said, wow, what did you do? Oh, I ironed all my life. Well, that is great. That must have been hard work. So you give respect to what they did because, you know, everybody's important. Everybody can't be a doctor. It's okay. But you got to respect people for whatever they were able to accomplish in their lives.
Everyone is a human. Everyone is human and gets that respect.
And you have to, they all want that, and everyone wants that. You have to find common ground. Like I'll even be like, if someone's wearing an Alabama shirt, I'll be like, hey, nice shirt, Roll Tide.
Right.
You know, it's something silly, but you know, it's once again like I'm a human, you're a human. We both like the same things. Right. Let's figure out this problem together and give you some good care.
I'm sorry, there are a lot of ethnicities. There's Dr. Clive Callender. He was at Howard. He always used to say, there are not multiple races. There's one human race. A lot of ethnicities, but there's one human race. There's only one planet that we know of right now that can support life. There's only one human race, period. A lot of ethnicities, but ain't nowhere else to go. You can't like hop on a shuttle and go to the moon. This is all we have. If we don't have each other and take care of each other, we ain't gonna have nothing.
Right.
So it's as simple as that. We gotta take care and love each other.
Right. And like you said, there's only one race, which is the human race. And for so long, especially going back to these papers I mentioned earlier, you read about how so many scholars, notable scholars, Plato, Aristotle, on through some of the major people throughout each era kind of perpetuated the idea of subspecies within humans, where certain species were lesser than, certain species had different intellects, different physical abilities to divide. And for so long that has happened and even perpetuated throughout Henrietta Lack's story. And the respect that we've all been talking about was not given to Henrietta Lack's family. And Allison, I want to take your points, but yeah, not letting them know or giving them any type of acknowledgement for so long. Allison.
Yeah, so thank you guys so much for your input on that previous question. And just moving forward with Henrietta's story. So the Lacks family was not even aware of the cell culture until 20 years after her death, which would have been in the 70s. And so, like some of you mentioned, you read the book written by Rebecca Skloot, The Immortal Life of Henrietta Lacks. And this was just an excerpt taken from the book by one of Lack's daughters, Deborah, and she posed the following question: but I always have thought it was strange. If our mother's cells have done so much for medicine, how come her family can't afford to see no doctors? Don't make no sense. So just a question to pose to you guys. although it's a complicated legal situation because Johns Hopkins never patented the HeLa cells, and therefore they don't own the rights to the HeLa cell line. And technically anyone who purchases them owns like the rights to that particular cell line that they own. So, but what are you guys' thoughts on the family receiving financial compensation, especially given that, you know, they weren't some wealthy upper middle class family, like they were still struggling with their own responsibilities? Feel free to voice it in the chat as well.
Well, I didn't know that they hadn't patented it. You know, if they had patented, then I think it would be a lot easier to go after them. But the honorable thing to do, Hopkins, they got billions of dollars stashed away. I went for my class reunion a couple of years ago, and like they were billion-dollar buildings given by Bloomberg and an oil sheik that they had built. They have money; they could give the family something. But that would be the honorable thing to do. Is to say thank you very much. You know, sorry we didn't let you know about this years ago. We're extremely grateful for everything that your family did, and here's something that we want to give you and your family, and give them health care for the rest of their life, or something like that.
We have Ryan Halas in the chat with a couple thoughts.
Sure.
First off, looking into why Henrietta Lack's story and the story of Dr. Sims isn't included in medical curriculum. If anyone wants to comment if that is or isn't included. And also surprised that the medical school admissions rates don't reflect the percentages of the minorities.
Oh,
which is
that's a different question.
Yeah, that's a very good question.
I'm glad you asked, but we struggle mightily to find enough students that we know we can get through. But this has to do with decades of lack of opportunities for African Americans in the United States and Hispanics as well. That's where a lot of that comes from, and still today in our rural Alabama, but also just not having the access to educational opportunities. You know, we go through a lot of folks. Even this year's class coming in, there was a decreased number of applicants from Alabama, and that's the vast majority of folks that we get for our underrepresented minorities because it costs so much from out of state. We get them, but it's harder for us to keep them here because tuition's twice as much. And so we admit them, but we can't keep them because we're a public school. We don't have $70,000 to give somebody. We'd love for them to come, but if they can stay home and go for a quarter of the price, even though we admit them, it's hard for us to get them. And so we're really dependent and try to grow our own as best we can. And that's why we partner with UAB. But what you're asking is valid, but it's a societal issue that is permeated not only medicine, but all facets of having opportunities for minority population.
Right. And Ryan brings up a good point of reaching back to high schools and educating, cultivating them. UAB definitely does have efforts to do that. And that is probably one of the best things you can do is try to reach back as far as you can and show students earlier on that it's possible. Because it'll be harder to get a student who's a junior or senior in college to start thinking about medical school and to go through everything to change their career path versus if you get to someone early.
I know you'll get me going now. Look, the TV, media, it is fine for a black male, black woman to go play a sport than it is become a professional. They don't talk about it, but if you want to go do hip hop, sing a song, play basketball, yeah, that's fine. But there isn't enough positive role models. So the mass media has a big thing to do with us not having positive images.
And I think about that with, okay. I won't speak. Deslin, you can go. I know you haven't spoke yet.
Hey, No, you're so right, Dr. Young. I just wanted to go to what Ryan Hollis said. And Michael, I think this could be a laid back conversation one week, but I'll just say this. You're right. We have to start at high school. And I think that's the key I think people don't understand the difference between white supremacy and a white supremacist. Most people are not white supremacists. I think that's like KKK people, neo-Nazis. Most people aren't like this. But what most people are affected by white supremacy. And I think you have to understand that we're like subconsciously, like Dr. Young was saying, yeah, we can see a Black man being a basketball player, a football player. We can use their bodies to entertain us, but we don't want to use their minds to help us and help our society. That's one of many facets of white supremacy. So if you're a little Black boy and you want to become a doctor, that's not the images that you're seeing. You don't see Black male physicians, so you don't think it's possible. And I think that's why we have to start when they're young to say, you can do this, you are capable, before they get into college, and then they don't have the skills to succeed. It's not that they can't succeed in medical school, it's just that they don't have the same cultivation and grounding to get to that point. And so I just want to say that. I'm gonna get off my soapbox. Yeah, we can make this a thing, Michael. That could be a discussion one week.
You're absolutely right, Deslin. Black folks, everybody got the same intellectual level.
Mm-hmm.
Look, there are great civilizations that were built in Africa, but you don't hear about them because they're the victors write the history book. But everybody has the same, but it's about the environment and about the positivity and put forward with that. And we've just got to do a better job overall. You all are the next generation. I'm doing what I'm doing for you because of what Dr. Watkins did for us at Hopkins. I felt it was my responsibility once I got in a position to try to help make change for you all, since I was able to do it once I got here. And the next step is for you guys to keep it going. That's how we educate and how we bring about change, by educating folks and bring everybody into the conversation, which is what you're trying to do.
Speaking on what Deslin mentioned, the difference between an individual racism and like societal or institutional form of racism, white supremacy in the form of Ku Klux Klan member versus institutional. This was something good. I meant to put this in, but I guess I forgot to. But these points here of how these mediators can influence that, where when you bring in the aspect of power, the controlling of resources, defining standards, and defining problems, when a certain group is able to do that, you are able to control an institution. And that's an interesting thing I've been seeing the past month or so, the idea of professionalism. What is considered professional? A couple weeks ago, there was a big article that was meant to be published about vascular surgery residencies and looking at women specifically among all the residents, and certain actions and certain posts on social media being defined as not professional. And one could say that in a field that for the longest time had been dominated by mostly white males, that an internalized misogyny in number 3, establishing the societal standards, affected that. And I know I've spoken to a lot of people in passing about that, but that could be something that is on that level of, it's not an individual aggression or anything, but just looking at the standards and traditions over time and the lack of any outside influence or any people coming in with different perspectives for such a long time, where certain standards are never challenged, such as a woman wearing a bikini on Instagram, and that's still her still being able to be considered a professional and not being unprofessional just because she's wearing a bikini.
Well, I don't know what your next section is, but I'll tell you. I left Hopkins and went to Thomas Jefferson in Philadelphia. I was the only African-American surgeon there, resident there for my entire 6 years there. I may have been the only one who was there. They treated me well. I worked my behind off. They didn't cut me any slack. But I was the only one there. And I think the only reason they took me, one of the reasons, that I came from Hopkins. Because they didn't perceive that any other African American, well, if he got through Hopkins, he must be able to get through us. You see what I say? In terms of the standards and that idea that are you capable enough? Can you really do it? And therefore, I had to go and prove that, yeah, I can. I'm just as smart as these other guys. I can be better. And my mother always said, you got to be twice as good to be half as accepted.
If I can interject for 1 second,
sure.
I'll let you finish, Dr. Young. For anyone who has to go, right here is our next event where we'll have Malone, who wrote the book about clinical signs of colored skin, Mind the Gap, as well as dermatologist Dr. Tiffany Mayo will be speaking on this. So I am also posting this link where if you have feedback, if there's a certain talking point you want to see covered, and I'll give you the opportunity to cover that. Where if there's a certain thing within the topic of race and medical education that you want to speak on, definitely submit that link and we can get together and see about making a slide or something where you could speak on that. But you can continue, Dr. Young.
And so Miss Erica also had a comment. I know she's been
okay. Yeah.
No,
yeah,
go on. No, I'm good. Keep going.
Hey, I'm sorry. I'm going to have to go in just a minute, but I have more of a comment than and sort of a question. I know all of you, first of all, thank you, Michael and SNMA, for putting these discussions together, because I think they're just so important. Many of the comments that have been made, particularly by you, Michael, and Deslin and Dr. Young, regarding our institutions and race, regarding what race is and the difference between racism and white supremacy and being a white supremacist. I really appreciate all of those comments because they're so important. When we talk about, the medical field or medicine, it is an institution. And the question I think that's being asked or being discussed, the undercurrent, is this concept of race and how race has really played out here in the United States. It's, racism has impacted, has been around for a very long time, and it has historical underpinnings that have affected African Americans in the healthcare field. Race is at least in part responsible for the fact that African Americans, since arriving here as slaves, have had the worst healthcare status, and the worst healthcare outcomes of any other racial or ethnic group in the United States. And a lot of doctors, there's a lot of philosophers and scientists of each era that have been involved in creating and perpetuating racial inferiority, methodology. And that is carried out and been carried forward through stereotypes, which have impacted our institutions, this one being medicine. But if we think about, we could carry that same concept to education. The question was asked about why we don't have more African Americans or people of color in medicine. Well, education being another institution, race has impacted that. Think about what's happened in the last several months regarding our law enforcement. That's another institution, and how race impacts that as well. So I think it's really important to understand the concept of race in the United States. And I think that would be an excellent conversation in and of itself, and how it was established, how it was informed, and how it has impacted medicine overall.
Yes, yes.
And impacted our society and as a whole.
And definitely that is something that could be, we can keep that in mind as something coming up, because that is, you're right, the more you look at those institutions and seeing, like, when you bring up the Justice Department, the idea of race, not only with Black Americans, but like looking at New York and how they had to change the idea of what the institution was to allow Sikhs to serve on the NYPD while still having their traditional headdress on. And looking at not only race, but religion and all of the things that make identity to challenge those who created that institution. So yes, that'll definitely be a good topic.
Right. So gotta go, everybody. Really enjoyed it. Looking forward to the next one.
Thank you, Ms. Erica Brown. Last couple points. So while all this was going on with Henrietta Lacks, before her story really came into the limelight, the U.S. Department of Public Health began an experiment in Tuskegee, Alabama. And this, I'm sure we all heard of it. And that Tuskegee experiments went throughout Henrietta Lacks' story and really came to light and came to an end later in 1972, where they were treated for bad blood and given false treatments for syphilis, and really not even told of their diagnosis of syphilis. They were just told the general term bad blood. That could mean a bunch of different things. And penicillin was introduced in the middle of this, and it still was withheld. And looking at the ethics of that, where you have a longitudinal study, but by consciously withholding treatment, you have deaths, transmissions of syphilis to wives, and children born with congenital syphilis. And like we mentioned earlier, what came out of this, you saw IRBs being established at universities. You saw informed consent become widespread. And in 1997, Bill Clinton came out and apologized not only to Tuskegee, but to the larger African-American community. And coming out of this, the question of furthering distrust. And after Henrietta, after Tuskegee, you see so many more incidences that have so much distrust with the crack epidemic and the overall drug epidemic that came into the United States, where people, because of their distrust, attributed that to the government. HIV and AIDS attributed to the government, because you have such a pattern of actions where it's so hard to not think about that. And beyond just African Americans, we're at a point now where we're facing a pandemic, and you have a large American population calling it a hoax. And so how do you build trust in the institution of medicine? And that's kind of the bigger question of this. And Dr. Peterson, Dr. Young, looking at COVID that we face today, and you probably both have faced so many people that just don't believe in it. How do you build that trust?
It's gonna take time, man, because there's too many disparate voices. You know, what I was just asking a physician earlier today, why is it that we have not had an NIH-backed study over the last couple months at multiple centers looking at whatever possible treatments and a randomized control, however you want to set it up, that everybody would agree on, to come to some conclusion how to try to treat this stuff early on? I don't understand that. Why there have been studies back and forth, what works, what doesn't work, and that's what increases the distrust and the confusion, because you have one group of physicians saying one thing, another group of physicians. If the medical community can't get their act together, and this is 2020 with all the science, all the stuff we have, why can't we have a study to once and for all determine what is the best prophylaxis and treatment of this disease early on? Later on, it's a bear, but there's got to be something you can do early. And why can't we answer that? So that's part of the trust that has to come from the medical community. And I think we failed the U.S. population horribly in that.
Yes, sir. Yes, sir. And Dr. Peterson?
Yeah, I think it's a very challenging thing, but it has to just be done one patient at a time, one encounter at a time. And it takes commitment from the entire system to treat people, with respect, even if they have an opinion that is very different from the one that we hold. We have the luxury of a medical education and we understand the science behind a lot of this, but I've found I've gained some traction with patients who have very disparate views. When I sit down, I'm like, I'm sensing maybe a little bit of hesitation with what I'm explaining here. Would you mind just kind of explaining your viewpoint to me for a little bit? And then you got to sit and genuinely listen, because a lot of times they have very legitimate reasons for their resistance. And sometimes their resistance is just a frank misunderstanding that you can come together and be like, oh, I understand you're coming at it from this way. Actually, this is another way to explain it, and then they get on board. But if we're not willing to give them the respect of listening to their viewpoint, they're never going to want to partner with us individually. And if they can't do it individually, they never will partner with us as an institution.
Right. You summarize it perfectly, Todd. Trust and listening to people and meeting them where they are and respecting them is basic human desire.
Right. And even not in the big scheme of COVID and the pandemic, I was speaking to someone I'm close with last week. I had to go to see a orthopedic specialist and to get referred to for physical therapy. And she was telling me how whenever she sees a doctor, she feels like she's never heard. And she's speaking, but is never really connecting. And she's being talked to and spoke at, but not spoken with. And there's so many other people I hear that with. My grandma's told me that. And different people, especially women, telling me that when given a male physician, that they feel like nothing they say really has any impact on their clinic visit.
And that's true. I think we just have to own that and do better, frankly.
Yes, sir.
I wish there were easier fixes, but it takes everyone being very intentional. And I think that's something that we should do a better job of teaching in medical education, the importance of that, because everything is so, you got to learn these facts, you got to learn this algorithm, you got to prescribe this thing, but it's a field ultimately about connecting with other humans. So we forget that.
Yes, sir. And I feel medicine is moving towards that. You see the emphasis moving away from MCAT scores, preclinical step scores, and moving towards more holistic and more clinical oriented aspects and metrics to measure people. I can see that definitely coming, especially in the next decade.
It's coming. I think we're doing our best on the medical school side, but then there's a big jump to the residency side, because not all schools do this. A lot of schools don't have this as a linchpin of what they're trying to teach their students, and so hopefully as you guys go out, that you can bring some of what we've been trying to teach you to whatever residency program. Hopefully it'll be here, or whatever residency program that you go to, that they may not hear this message. A lot of schools don't have that holistic approach. I know a lot of residency programs don't. They're so focused on scores that you can get pathologic individuals coming through. I tell you, some of the residents we come through, I said, how did that person get through? Oh, they had good scores. So what? I don't care. The scores only say, can you pass the test? It doesn't tell you what kind of doctor you're going to be. But anyway, hopefully we're able to instill these things in you, and you guys can help us, help you all to figure out how to make the curriculum better, to bring up all these issues that you've done and work on the curriculum, which I know they're reviewing now. So it's been great you guys brought that up, and action is coming. It takes time, but they are looking into it to try to remove the racism and comments out of that, and educating all the module directors and all of that. It's going to take time, but it started because of what you guys brought up. And just continue to engage as you guys have, and we're going to listen to you and work with you and let you know where things are going.
Yes, sir. Yes, sir, because that is huge, moving away from the idea of only thinking about a number, only thinking about a step score, because a large population, that's the only goal to a lot of people, is just a score and not developing as a person.
Very true.
Allison has a question. That was just, yeah, I see what you're saying. Does anyone else have any?
I'll go back. In reference to what she said, it's one reason why I didn't stay at Hopkins, because everybody was so cutthroat. Everybody was trying to push over everybody else. The residents didn't help each other. Man, they just beat the snot out of each other. But the program I went to was tough, but at least everybody helped each other. As a chief, I would go and do admission so we could all get out of there. And my chief did the same thing, because you didn't get to go home until everybody was admitted and you went through all your patients to know what was going on. And I found that environment at Jefferson to be much more conducive to what I was looking for than that cutthroat environment that was Hopkins. I don't know. I think it's probably still that way. But I had a long discussion with my mother. I said, they people crazy. And everybody, why do you want to leave? It's Hopkins. I say, because y'all crazy. But again, when you're looking for some place to go, you got to find out what's going to suit your personality as well. Are the people going to take care of you? Are they going to care about you? And are you going to have the support you need? You know, you're going to get used to it in medical school. We're not perfect. We're trying. But you got to try to find a place that's going to nurture you and be understanding of what you're going through. Residency is hard. This stuff is hard. But what we do taking care of patients is a big deal. Not everybody can do that in the world.
Yes, sir. Yes, sir. And that, getting to that. Does anyone have any closing questions, closing remarks, and we can wrap up?
I know we got to go. I can hold my question for another talk, but or if nobody wants to answer it. But I just think the parallels with just the holes in medical education to me are really are pretty gaping, and it varies tremendously based on the curriculum. But I mean, the lack of conversation about racial outcomes just not there. And I mean, and I draw parallels and have been at my personal school with, I'm at Alabama College of Osteopathic Medicine, a couple hours from you guys, is a lack of conversation about obesity education. Like, that is the leading public health crisis in America, or top 2 or 3 for sure. And like, we just say, like, don't, try to make sure your patients aren't obese. And it's like, that is not a tool chest. And I mean, these are literal crises in America, and it seems like we're barely scratching the surface. And I don't understand. I'm just at a loss. Like, how can we do this?
Well, thank you, Ryan. You're right. There are a lot of countries that do a heck of a lot better than we do with preventive care. No, we're so focused on the back end with all these big interventions and all this medicine. We got to take care of people grassroots, so you don't get to the point where you need a kidney transplant, or you don't get to the point where you have severe hypertension. But that's one thing that we're trying to do at your school. I know you're doing yours as well, to focus on preventive maintenance and primary care. What is it? Franklin said, an ounce of prevention is worth a pound of cure. We've got to do a better job of taking care of people from the beginning. But then again, that goes into socioeconomic issues, food deserts, all of that. It's all interwoven. So we still have a long way to go in this country in multiple areas.
Thank you, Ryan. That is big, getting to the bottom of that and seeing those are the real pandemics going on. I'm going back to this point. It's a crisis. And that was a point here. Yeah. That is something where this point, feeling that medicine is kind of indifferent to crises that are specific to certain groups, and addressing that is huge. And these papers were great. And in closing, August 14th, we have Dr. Mayo and Malone McQuinde, who wrote Mind the Gap, dermatologist Dr. Mayo, same link, same time, 2 weeks from today. If you want to stay up on what's going on, feel free to search hashtag org-SNMA on Slack, and it'll come up in the search bar, and you just hit it and you can join or follow on Instagram. Contact info, if anything, if you want to email or anything. And this link for feedback, if you want to suggest a topic or if you want to give feedback on this talk. But with that in mind, thank you, everyone. This is great. I'm glad we can keep this going. Thank you, Dr. Young. Thank you, Dr. Peterson.
Thank you very much, Mike, and everyone else.
Thank you. This was great.
Yes, thank y'all, everyone who came through. SMA members,
Mhm.